Jim, Mike Thompson mentioned earlier, he gave lung cancer as an example, and of course, across immunotherapy, there are so many companies endeavoring to move this research along. So let's say you had lung cancer, or one of these others where this is big, although it's going on in the hematology area too. So a patient says, oh my God, there are all these trials, and I might qualify for 1, 2, 3, 4. How do I prioritize? What do I bet on? And maybe my own doctor is doing more than one. So what do you say to patients if they become receptive to being in a trial and there's more than one trial that they qualify for?
That's a very good question, and it's a nice kind of problem to have choices of trials. I think, Andrew, the best answer is a patient needs to look at what they are looking for. Are they looking for longevity? Are they looking for something that's going to extend their life? Are they looking for a trial that maybe will greatly improve their quality of life? Perhaps they might be in a trial that gives them 1 oral pill a week versus 2 injections a week. So there are certainly effectiveness endpoints. There are different things that patients find of value. But to answer your question, it really comes down to each patient needs to ask themselves, what is it that I'm looking for in a trial? Do I want something that makes my burden lighter? Do I want something that's going to extend my life? How much am I willing to accept as far as potential problems versus the standard of care that I know what the problems exist with if I don't go on a trial?
Right. And so that's a question we got in, is trying to assess that. One was about how do I prioritize? The other is, by being in a trial, Mike, is it going to make me sicker? Like, do I have to go through the valley of the shadow of death to get, hopefully, to a better place? And how do you discuss that with your doctor when not everything is known?
Yeah, so maybe I'll kind of step back and say, for phases of trials, phase 1, the intent, both ASCO and NCI say the intent of a phase 1 trial is therapeutic. But the statistical design is to evaluate safety. A phase 2 is to look at initial efficacy or how well it works, and phase 3 is to compare versus standard of care, the efficacy. So there's other types of designs, phase 0, phase 4, and other things, but it used to be, I think, we would say, don't go into phase 1 unless, that's the last option, because you've already gone through the safety and initial efficacy if it's a phase 3 trial. It costs a lot of money to do phase 3 trials, so fewer are being done now. And we're kind of finding that in this era of precision medicine, people are going on trials, and there's no one rule, but I look at it as if it's a study involving a lot of different groups of patients, a lot of, it's not as individualized to you. I don't know, but I think it'll have less of a benefit probably than if it's something like a study designed for BRAF melanoma back when that was a study, and you have BRAF. Well, it's targeted towards you. It doesn't mean it'll work, but even if it's an early phase, so phase 1 or 2 trial, it's really aimed at your disease. And, we're finding this with venetoclax with T1114, and there's other, markers, FLT3 and AML, all these things. And sometimes we find that the drug doesn't work like we think it's going to work. The ALK and ROS story in lung cancer, it may benefit other people that we didn't recognize before. And that's part of, we're trying to find people besides T1114 that respond to venetoclax in myeloma, because it looks like, some people will. But I think as we're getting more targeted therapy, it doesn't mean there's no toxicity, but it at least has the suggestion that we're targeting it more at your specific cancer. And some of these pills can have as much toxicity as IV chemos, but our aim is to decrease toxicity and increase efficacy. And I think, like Jim said, you got to look at the different trials, and hopefully with a physician who has time to sit down and run through several scenarios. And some people will take the most aggressive therapy because that's what they're after. And some people will try something that's easier and is closer to home. So everyone's values are a little bit different, and you have to try to individualize it to the patient.
Right.
The other thing about trial matching is, besides clinicaltrials.gov, there's myeloma and other groups that are doing these matching, so you can put in characteristics of your cancer, and you can try to filter out and get a closer approximation, including in clinicaltrials.gov, you can click on the states in the surrounding area or how many miles you're willing to travel.